So, some of this we've covered in the previous talk, so I'll be able to move a little bit faster here. But I think in surgery in general, we're taught to treat the pathologic processes, but limit adjacent segment disruption, right? I mean, in order to get a good outcome in this day and age, we want to try to do things less and less invasively. And in spine surgery, in a lot of ways, at least in the United States, we're very much behind the curve because minimally invasive surgery, while it's growing, is still only about 15% of the surgeons are doing minimally invasive surgery. But in other types of surgery, abdominal surgery, if you saw an incision like this, that you would say you went to the wrong surgeon. This type of surgery is always done through little openings, but in spine surgery, minimally invasive still comes with a taboo. Now, it's changing a little bit, and when we think about lumbar surgery, nowadays a lumbar minimally invasive operation is considered to be a reasonable option by most surgeons. But in the cervical spine, if we go back to that patient with the disc herniation that we looked at earlier, most people are still doing this operation as opposed to doing something potentially less invasive. And this is an operation that we started doing in the 1950s. So it's been many, many decades, and we have to imagine that there have been advances made. And we know that everything that we do, this is the gold standard operation, but there has to be things that we can do better. So when we think about minimally invasive, how can minimally invasive procedures make that operation better? And so what are the things that maybe we can impact? We can maybe impact dysphagia. We can definitely impact adjacent segment disease. And we should be able to eliminate adjacent level ossification disease. Those are the three things that we can do better compared to a ACDF done in a traditional fashion if we can think about doing things in a less invasive manner. So a zero-profile ACDF accomplishes at least two of those things. A zero-profile ACDF, by not having a plate, allows for a reduction in dysphagia, and it also allows for elimination of adjacent level ossification disease as long as you can obtain a solid fusion. And this is the post-op CT scan of that patient. We can see a very solid arthrodesis, and the key thing here is that in the devices that were initially now about a decade ago created, the graft window was extremely small. There are much better options now with very large graft windows, and I would highly recommend, if you're doing zero-profile devices already, or if you are considering doing them, choose the device that has the largest graft window and the biggest footprint, because you don't want to compromise your fusion. That's very important. We showed this picture earlier of this patient getting to higher places. Again, a very positive impact on dysphagia, whether it's done at multiple levels or 2 levels. We published a study recently looking at our standalone cages versus our plates, and when we specifically looked at this, we saw that there was a lower trend towards dysphagia. So dysphagia is something that we don't ask our patients enough about, but in cervical spine surgery now, we are starting to consider dysphagia more and more, and we have clearly found that the plate does contribute to some amount of dysphagia, even though for years we said the plate doesn't matter, the plate doesn't matter. It matters. Other authors have looked at this as well, where they saw that there was a significant difference in dysphagia rates. And in terms of adjacent segment degeneration, this was one small study, and we're looking at this in our patients now as well. But there was a trend towards a reduction in adjacent segment degeneration, perhaps most likely, I think, because the adjacent level ossification is eliminated. What about patients who have multiple level issues, right? I mean, in addition to the radiculopathy, the other big cervical spine problem is myelopathy, and we can't ignore the myelopathy patient. So we've started recently doing this, and I think our experience on our first 25 patients is going to be published in a couple of months, doing a minimally invasive cervical laminectomy at multiple levels. So this is an example of one of our patients who has multi-level cervical degenerative disease, has multi-level cord compression, going over 3 levels. And this is a patient that you would consider either doing a multi-level fusion on or coming in posteriorly, anteriorly, either way, an operation that would involve perhaps a laminectomy infusion or an anterior discectomy infusion. But this patient, surprisingly, has no neck pain. So this person has pure myelopathy, and I think a laminoplasty on this patient, we always worry, could potentially, especially with the amount of degeneration, cause this patient neck pain. So this is a patient that we've started to do a minimally invasive cervical laminectomy on, and what that involves is instead of doing this operation, we're doing the same operation but through a small tube. And so this is the patient before surgery, and this is the patient after surgery. So this is the pre-op and the post-op MRI. And what we've done is we make multiple 14-millimeter openings. In this scenario where we want to access at least 3 levels, we'll make 3 openings, 2 on the right, 1 on the left, or 1 on the right and 2 on the left, depending on the side of the pathology. And we will do a bilateral decompression by opening up space not only under the lamina, but in the cervical spine. The key thing is getting under the spinous process and creating more space for the spinal cord to float away. And this can be done at a 3-level decompression. This patient can go home the same day of surgery and with very limited pain. This is the post-op MRI on this patient at C3, 4, 4, 5, 5, 6, 6, 7. We can see post-op we have good CSF restoration. Does it look as pretty as an open laminectomy? It doesn't. We don't see the cord floating away as much, but I can tell you that with the recovery of myelopathy findings and the fact that we didn't have to fuse this patient, our early experience has been very, very good with the MIS cervical laminectomy. This procedure was born out of a procedure that I think is much more common to us, which is a cervical foraminotomy operation. We've published on this in several areas, and before you can do an MIS cervical laminectomy, you have to be able to do a good posterior cervical foraminotomy through a tube. So I generally like to use a 14-millimeter tube for this. I like to dock the tube because the lamina is not very wide. You want to dock the tube pretty close to your spinous process so that you're seeing the medial third of your facet joint. I use a Jackson table for all of my patients where I do this operation. I put the face in a face holder and I do it laying down, not sitting. I find this to be the easiest setup. I put the face in a faceplate. I have good access to the neck, and this way I can bring my C-arm if I'm using a C-arm, although now we are doing this navigated, but I can have my C-arm parked right in there so that I can dock my tube under fluoroscopic visualization. Once the tube is in place, I get an X-ray just to confirm that I like the angle for my cervical foraminotomy, and this is a view through the tube. What we're looking at here is the upper lamina, the lower lamina, and this is the lateral mass junction here, and we are just starting, this is the burr that is just starting to perform a laminotomy that will then extend with our kerrison. Here we can see the nerve root here, and we're right in the axilla of the nerve root to access a disc fragment. This is a procedure that we were doing for a discectomy. And then this is the post-op. It's a small opening. So you have to be comfortable doing, obviously, a good posterior cervical tubular foraminotomy before doing a laminectomy, but it's a good operation. We've now started to do some minimally invasive instrumentation posteriorly. This is just an example of that, where we can use our drill guide through our tube to pass lateral mass screws tubular. I think it's a good option in a patient either who has a previous ACDF with a pseudoarthrosis, and at one level we can place percutaneous screws without a significant dissection, or if you want to augment a laminectomy with instrumentation, and we can access multiple levels this way. Other cervical options that are minimally invasive include something called the D-Trax. This is a facet fusion device. I don't have a lot of experience with this particular procedure, but I think that it is a nice option. It can be done very minimally invasively through a tube. I think it's a nice option to back up a multi-level ACDF if you want to have some posterior fixation, or if you have an anterior pseudoarthrosis that you then want to treat posteriorly. I think that this can be a very nice option for that. The concern, of course, is are we creating kyphosis at the segment? And again, like I said, I don't have a lot of experience with this device, but I do think that it does appear to be a nice option. This was a nice study done out of Chicago looking at that device and showing that it can increase the foraminal dimensions for these patients. Obviously, when we consider minimally invasive surgery, we have to be worried about radiation, both to ourselves and to our patients. As we do things less and less invasively, we have to use image guidance. You know, I often tell my fellows that we're starting to blend between surgeons and radiologists. You know, I'm not exactly sure who I am anymore. And but importantly, what we don't want to have happen is our hands getting radiated, our eyes getting radiated. And so I think using some sort of navigation or robotic guidance is going to really allow us not only to increase accuracy, but also to reduce radiation, and I think that we can do these procedures more commonly. So I've completely shifted towards navigation guidance for a lot of my cervical work, and this is the navigation that I use, and this is just localizing, again, a cervical foraminotomy, where we're using targeted devices, and this is very helpful because this is a patient we were doing a C7T1 foraminotomy, and this can be a very hard level to localize using plain x-ray because the shoulders are in the way, and so using navigation we can localize much, much easier, which can be very helpful. I think the take-home here is that cervical minimally invasive procedures, they're still lagging behind lumbar spine, but I think as we start to be able to do things with more navigation, more robotic guidance, and if we just start thinking about doing how we can make improvements, I think over the next decade, this is where we're going to see the largest growth in minimally invasive surgery. Thank you.